With systemic mastocytosis, there's been enormous enthusiasm around Evapritinib, which is a highly potent and highly selective inhibitor of mutant KIT. I have been fortunate to be involved with its development, and we've had several oral abstracts over the years at EHA and ASH. This year was no different. There was an oral and several posters. So again, this is a very active drug. It's already known. It was actually an ASH plenary session in 2017 presentation. It's already known that it really dramatically, robustly decreases the KIT allele fraction, the mutant KIT allele burden, the bone marrow mast cells get cleared, the tryptase level comes down, and the spleen shrinks. So we've all seen these very dramatic waterfall plots in prior presentations. So this year's update was from the Explorer trial. This is the phase 1 trial. There is a phase 2 trial, but that has not been presented at a public meeting yet. So the Explorer trial had about 80 patients. It's a phase 1, so you had your usual dose escalation and dose expansion, and there was a further expansion of the 200 milligram dose, because that's really the dose that's going to go forward in advanced systemic mastocytosis. Again, very important to note for our viewers who may not do this very much. It's a very rare condition that we are talking about advanced SM here. There's a separate development program altogether for Avapritinib in indolent and smoldering systemic mastocytosis. That's called the Pioneer trial. But anyway, coming back to Explorer, the phase 1 in advanced SM. So about 80 patients, and 53 of them were evaluable for response. You have to meet all these criteria that are called the modified IWG ECNM MRT. That's a really long abbreviation, criteria. So these criteria really focus on resolution of the C findings, as these are called, basically organ damage. So resolution or improvement in organ damage, and that's known as a C finding in the field of SM. So the problem is that these criteria are intuitively a little bit difficult, and also just sometimes difficult to apply to patients, which is why, you have these 53 evaluable out of about 80 patients. So you see why a lot of people are not evaluable, and there's a bunch of reasons for that. So anyhow, as a segue into the abstract from this year, the focus this year was on PPR, or pure pathologic response. So when you have a drug that is this active, that hits the target, right, you may want to look at not just resolution of organ damage, which is clearly important, but also the biologic measures of how well it does what it's supposed to do. So clearance of the bone marrow mast cells, reduction of the tryptase level, reduction of the mutant KIT allele burden. These are the three things captured in pure pathologic response. It just simplifies things, makes it more intuitive, I would say. And what we saw was when you applied these criteria to those same 53 patients, you had about the same rate of overall response, right around 75, 77, around there. But the complete response rate went up quite a bit. So you had a big increase in CR rate when you used these criteria, because with the old criteria, with the C findings, it can be difficult to document a complete resolution. Whereas here, you are showing that you're killing those neoplastic mast cells. And it increased the number evaluable, which went up from 53 to 64. So you can now evaluate more patients with these simpler criteria. So going forward, I hope that these will be adapted into other trials. There are other drugs being developed in the field. Hopefully they'll be accepted by professional societies. So this was a start in introducing to the field a new set of criteria.